This is not a job, it's a mission. A mission of saving human lives since 1989 for Padma Bhushan Dr. Tarlochan T.S.Kler, India's renowned interventional cardiologist. Performing more than 25,000 coronary, renal, carotid, and peripheral angioplasties, Dr. Kler is a pioneer in electrophysiology. A revolutionary in interventional cardiology, he established the first dedicated electrophysiology department in India and initiated radiofrequency ablations program in 1993. Spreading the most important medicine, which is trust amongst patients, Dr. Kler is the first doctor in India to implant an ICD, CRT-P and CRT-D. He also did the first HIS bundle pacing in India in 2015, instrumental in starting RF, ablation and cardiac devices implantation program in many centers in India, Bangladesh, Nepal, Sri Lanka and Pakistan. Dr. Kler is a legend of a teacher and a leader in the history of interventional cardiology. In the latest episode of ETHealthworld's Touching Lives, watch Dr. Kler explaining the latest developments in cardiac care and what keeps him going.
We have Dr. T.S.Kler, the Padma Bhushan, who's a renowned cardiologist in the country, who's currently working as a chairman, Fortis Heart and Vascular Institute at Fortis Memorial Research Institute. Thanks a lot for joining us and taking time out of your busy schedule, doctor.
My pleasure.
I just wanted to know, how did the COVID-19 pandemic is still affecting the field of interventional cardiology? And are there any aspects of this shift that have now become a standard practice that is coming?
Right. See, first of all, I want to say that COVID has affected cardiovascular disease, or I would say the other way around, that almost 18 to 20% patients who had moderate or severe COVID, they had cardiovascular manifestations. Those manifestations were either more heart attacks. Why? Because during COVID, the blood coagulability becomes more. So if somebody has a 50 or 60 or 70% blockage, the chances of clot formation were more during COVID. Number one. Number two, there were also pseudo heart attacks. Pseudo heart attack means that patient had a chest pain and they came to emergency with ST, ECG changes of heart attack, but you do your angiography, they were either normal or no significant blockage. So those patients were because of the myocarditis, inflammation of the heart muscle by the virus. So we call it a pseudo heart attack. Thirdly, these patients had more chance of getting pulmonary embolism because the blood coagulability in the veins, in the leg veins, in the pelvic veins, particularly for those people who are obese or with diabetes, it is more, and people will get those clots going to lung is called pulmonary embolism. It can be fatal disease. So thirdly, there were a lot of rhythm problems. Patient had either sinus tachycardia, the heart rate 120, 130, or people had slow heart rate. Many of them, they had slow heart rate. And then there was a group who had atrial fibrillation. Atrial fibrillation is a disease where the rhythm becomes fast, it becomes irregular. So fourthly, out of the rhythm problems, patient who had severe disease or moderately severe disease, so they were in the hospital, they recovered, they went home, they had a sudden cardiac death. Okay. So this sudden cardiac death occurs usually because of ventricular fibrillation. So it's like a cardiac arrest, because many of those patients had myocarditis, which could not be detected because unless you do heart muscle biopsy or echo, if the echo shows decreased pumping capacity of the heart, you can say it is perhaps myocarditis. But where there were people, their heart function on the echo was normal, but still there was inflammation going on in the heart muscle, so they had ventricular fibrillation. Then many people had ventricular fibrillation or cardiac arrest because of the wrong medication. For example, chloroquine, erythromycin, these drugs they are known to produce QT prolongation on the ECG. And when there is a QT prolongation, we measure P wave, QRS, ST, and T wave. So what we call the QT interval, that means the start of the Q wave to the start of the T wave. So if the QT prolongs, these people are prone to get ventricular fibrillation. So that's how it's been reported because of that also. So it's a multiplicity of factors. Then when the COVID came initially, then we were not doing angioplasty for acute heart attack because that the recommendation came from the American Heart Association that treat them with the thrombolytic agents. But some of the patients we had to do angioplasty because they were severe heart attacks. If you don't open the artery in those patients, thrombolysis is much inferior. So those were the challenges. Now when the COVID is more or less over, I would say more or less. I mean, there are still now recently there have been cases occurring in many parts of the world, including India. But the good thing is now that the COVID which is occurring now, it's more of a nuisance, but there is not too much of mortality, and admission rate has not increased. I really don't think that there is a need to create a kind of great worry for our patients and general public. Yes, but I would say that the people should understand that COVID is not totally over. COVID is still lingering on. So we have to be careful. I think some degree of precaution is warranted, particularly for those patients who are immunocompromised. Immunocompromised means where the immunity to fight disease is less. What are those patients? Elderly patients, patients with diabetes, particularly severe diabetes who are on insulin, then people who are getting some kind of immunosuppressant drugs like steroids or methotrexate, anti-cancer drugs, or who have cancer. So those people should be very careful. They must wear masks to protect themselves. See, basically now this phase of the COVID, I will say, it is less that you will get the infection, but the people who are immunocompromised, they should protect themselves. Then people who have symptoms of COVID, for example, it's very difficult to differentiate COVID versus the usual viral infection. So if you are having upper respiratory symptoms, then even without testing, I would advise those people to wear masks to protect others. So it's a story of protecting others and protecting yourself.
Okay. To go on, I would like to ask, we could see, in recent past, among youngsters, there are a lot of, heart attack is occurring. You can see a lot of celebrities also, getting it. So the surge in heart attacks in young people, why is it happening in recent past? What is the reason behind it? There is a confusion. This is just because after the pandemic or due to the pandemic. Can you just tell us what it is?
So I think it's a very good question, and it is almost affecting every educated Indian, particularly young people, because there have been so many recent young deaths. 20 years girl dancing in the club, she just collapses and dies. And in Andhra Pradesh, I think there were 5-6 deaths in a very short span of time. I think there is a certainly increase in sudden deaths in the country, particularly in young people. Now, what are those sudden deaths? Why they occur? Sudden death usually means that if somebody dies within 1 hour of the onset of symptoms, it's defined as sudden death. Now, sudden death is usually, by and large, it is because of some heart rhythm problem. So there are 3 kinds of heart rhythm problems which kill the person ultimately. One is ventricular tachycardia. Ventricular tachycardia is a disease where there is the very fast heart rate coming from the lower chamber of the heart, a rate between 200, 250. Then the second is ventricular fibrillation. Ventricular fibrillation is the worst kind of arrhythmia. In ventricular fibrillation, the heart does not contract. So it does like this. There is electrical activity, but there is no mechanical activity. So when a patient develops ventricular fibrillation, BP is 0 and he becomes unconscious. So if you don't give an electric shock within few minutes, 2-3 minutes, the patient is dead. So ventricular tachycardia, ventricular fibrillation. The third rhythm problem which occurs is asystole. That means heart just stops beating. There is no activity at all. So why these arrhythmias occur? There are, I would say, around 15% of these sudden deaths. Ventricular fibrillation or VT or asystole occurs because of massive heart attack. But it is just 15% of those deaths. 85% of the deaths, there is already some pre-existing disease in the heart which may or may not be detected, because if somebody has been investigated, they will find it out. But there are many people walking having not much of symptoms, they have already existing heart disease. Now, one of the indicator to detect those patients is echocardiography, to understand how much is the pumping capacity of the heart. So for pumping capacity, we use the term left ventricular ejection fraction. That means how much is the capability of the left ventricle to eject blood. So normally it is more than 60%. That means if, let's say, at the end of the relaxed phase of the heart, there is 100 ml of blood in the left ventricle, with one beat it will eject around 60 ml. So that means 60 divided by 100 is 60%. So people where the ejection fraction has fallen below 35%, they are much more prone to get these rhythm problems in the form of ventricular tachycardia or ventricular fibrillation. So if you have detected these patients, then you first of all try to investigate the cause and try to improve the ejection fraction by either angioplasty or surgery or whatever. But where this ejection fraction cannot be improved and you think it is a permanent damage, then those patients can be prevented by implantation of a ICD, a defibrillator in the body, which is simple surgery. So a wire goes from the subclavian vein to the heart, and the device comes here. It's a little bigger than a pacemaker. It can detect any dangerous arrhythmia within 10-15 seconds, and if the need be, it can automatically shock. So those patients are given, they can be protected by ICD. Now coming back to again, why now? Why these deaths are occurring now? So many of us feel that these are occurring because of lingering myocarditis in many of these young people. Now, if you have myocarditis and if you exercise, particularly more than usual exercise, you can develop ventricular fibrillation. So my recommendation is that all those people who had COVID, for example, if they want to do exercise, first of all, they should not do any significant exercise 3 months post-COVID. After 3 months, they should have a cardiac assessment, ECG and echocardiography. If that is normal, then only you should start exercise.
Okay, and this is like any age group you would recommend?
But this is any age group. Mm-hmm. But the more shocking news in the country is young people dying. Youngsters, yeah. Why the shocking news is that 20 years girl or 30 years boy is not supposed to die while doing exercise. That's a shock. So the thing is, the young people should also understand that because of the post-COVID scenario, it is good they have a medical checkup before embarking on any exercise program.
Even once you are detected with COVID, it's better to not to do a hard exercise, like go for a very
checkup.
You have to go for a checkup. That is the recommendation.
Very good. Particularly if you have a moderate to severe disease. If somebody had a mild COVID, he never was admitted, he never dropped his saturation, and he has no symptoms, he doesn't have diabetes, he's not a smoker, those people don't need this cardiac checkup.
Okay, very interesting. A lot of important information is coming in. So to go on with, I would like to ask, can you tell us why a patient should not stop cholesterol lowering drugs or statins after a heart attack and have them for a lifetime? There's a confusion again in this, whether I should continue or not. So
very right.
Would like to.
Now before I answer this question, I will go back to the previous question about sudden cardiac death.
Yeah.
Sudden cardiac death is my passion and my subject. Yeah. I implanted the first ICD in India, 1995. So some of these deaths, for example, in younger people, they may have, they don't die many times because of the heart attack. There are other disorders. Like for example, one of the diseases is called hypertrophic cardiomyopathy. It's a genetic disease. Heart muscle become thick in these patients. So these patients, if they do sudden exercise, they can have a ventricular fibrillation. They can have a cardiac arrest. Similarly, there is a disease called QT prolongation. These patients can have their heart are normal on echo. The QT prolongation can be picked up only on the ECG by a cardiologist or a smart physician. Then there is a syndrome called Brugada syndrome, which may run in family. So there are other disorders also where a patient can die suddenly. So every time the people think heart attack, it's not every time heart attack. There are other disorders also.
So you're saying this would be like for the Asian community or the Indian?
Everywhere in the world.
Everywhere. It's
Yeah,
not
yeah.
for a particular ethnic
right.
group or.
So sudden cardiac death, if you see the whole world scenario,
Yeah.
below 35, the most common cause is not heart attack, not coronary artery disease. The most common cause is hypertrophic cardiomyopathy. But now the data may be changing just because of the COVID.
It is, or it.
Yeah, COVID means heart muscle inflammation, myocarditis, and on the top of myocarditis, if you exercise, you can develop cardiac arrest.
Okay.
Yeah. Now we come to the statin question.
Yeah.
See, 4 major risks of coronary artery disease, that means the disease where you develop blockage in the heart arteries, are hypertension, smoking, diabetes and raised cholesterol, particularly bad cholesterol, LDL. Now there are umpteen number of trials, randomized trials of thousands and lakhs of patients. They have clearly shown that people who are prone to develop heart disease, coronary artery disease, if they decrease their LDL levels, the cardiovascular events decrease very significantly. So now when we talk about the cholesterol lowering drugs or statin, there are 2 indications. One is called primary indication, second is primary prevention, second is called secondary prevention. Primary prevention means that you come to me, you never had a heart disease, never had a heart attack, but your LDL is 200. So this is very high, I want to decrease this LDL. Normally, in normal people who don't have heart disease, we would like their LDL to be below 100. Yeah. But if you already have a heart disease, some blockage in the coronary arteries, you had an angioplasty or somebody had a bypass surgery, then we don't want them to have again heart attack. So this is called secondary prevention, because you have already a disease, but you don't want the attack again. So statins are again very useful to prevent secondary repeat myocardial infarction, repeat cardiovascular events. So in secondary prevention, actually we would like to keep the LDL below 70 or even below 50 in high risk individuals. For example, somebody develops heart attack at the age of 30. In him, I want to keep LDL below 50 because there is a clear evidence in the literature that these repeat cardiovascular problems are much less if you use statins. So once your doctor has prescribed statins on scientific ground, you are supposed to take lifelong, until and unless there are some contraindications or the patient is not tolerating those medicines, but then there are alternatives available. For example, there is a very good drug which is called PCSK9 inhibitor. The name is Repatha. So there you have to take 2 injections in a month. This is much more efficient and it's a very safe drug. The only issue is cost of the drug is a little more. Yeah, but we need to keep some drugs to keep the LDLs low.
Over the years, in your experience as an interventional cardiologist, how have you seen the technology and treatment landscape develop? You must be seeing a tremendous change, right? So also, what is in your perception of patients towards new technology in interventional cardiology? How they are like?
Very good question. So you can say, Pratibha, that I think I belong to that era where lot of technology, lot of development has occurred in cardiology. See, when I was doing my DM cardiology, that time if somebody had a heart attack, he had a heart attack. There was nothing available. Even the role of aspirin was not clear. Even we used to give sorbitate, nothing more than that. But now it is just great that in heart disease, we can treat everything. We can do angioplasty, bypass surgery technology has improved, and new stents have come up which is very safe. The chance of recurrence is very little. For example, if you go to third generation drug-eluting stents, the chances of recurrence of this blockage is around 7-8%. When we used to do just balloon angioplasty, 40% people will come back within 6 months with the blockage again. Then we have a metallic stent. When the metallic stent came, this incidence became around 15 to 20%, but still 15 to 20% is high. But then came the drug-eluting stent. Then it became almost like 10-11%. Then came second and third generation drug-eluting stent. Now it is around 7-8%, which is a big development. It's still not zero, but there's a lot of development. Then lot of technologies have come to deal with difficult vessels. Heart arteries, for example, they are calcified, a lot of calcium deposited. So there it was very difficult to do angioplasty for those patients, but now we can drill those arteries, a technique called rotablation. Then there is something called IVL, intravascular lithotripsy. Like we blast the kidney stones, we can blast the calcium in the blood vessels. So once you break that calcium, then passing a balloon and a stent becomes easy. Now there is a laser available to cross uncrossable lesions, like somebody artery is 100% blocked and you are not able to pass the wire. You can take a laser fiber and you can create a small opening across that lesion. So I would say many more things have come in the interventional cardiology, and now actually that is why that if you see the number of bypass surgeries in the Western world, they are much decreased now. For example, I would say if 90% are going for angioplasty, only 10 surgeries are occurring now, or 10 or 15. In India it is still more because many people have more diffuse disease. But even in India now, the angioplasties are increasing, the bypass surgery is going down and down.
But any percentage, doctor, if you could? For India, like angioplasty, how it's increasing and bypass surgeries are like
it's decreasing, yeah, it's like, a graph like this.
Any percentage, you said US as a percentage of 50 or something?
In India, I would say now it's around 60-70% is angioplasty, around 30-35%
still for
bypass surgery.
Okay.
Now there is another area where a lot of technologies are come, areas heart failure. When people have refractory heart failure, previously it was end of the story, like a death warrant, that nothing can be done. But now we have technology to improve these patients. We have a technology called CRT, where a special kind of pacemaker is implanted. You can increase the pumping capacity of the heart. To prevent sudden cardiac death, we have an ICD, a defibrillator available. Then if for example patient is not suitable for CRT or he has not responded for CRT, then there are two more technologies. One is called LVAD, left ventricular assist device. So for this we have to do surgery. You put a tube in the left ventricle, suck blood, and there is a pump implanted just below the heart. It will throw blood into your aorta. And people can live up to 10 years, 15 years even with the LVAD. And then there is a heart transplant available. So a lot of things are available as far as the heart disease is concerned. So actually I always tell people that if a patient has a heart disease, he is intelligent and his family is intelligent and they have money, patient should not die from heart disease. Because if the heart is totally gone, you replace the heart. If you can't replace the heart, you give him LVAD. So a lot of things are available. Of course, these things, they do cost money, but ultimately, there's no cost of money in that matter. Person who can afford, at least there are facilities available. And I am very happy to share with you that in heart disease today, many hospitals in India, all across India, from north to south, we have facilities as good as any good center in the US or in the European world. Yeah. So our doctors are very capable. They have more skills actually than the Western population. So that way we are in a very, very good shape. The only challenge is I would say that when we talk about medical facilities, it should not be limited to just 30% of people who can afford, but there are 60 to 70% of the people who cannot afford these technology in private hospitals. I don't have easy answer for those patients, but there are answers available. I think the public sector needs to be strengthened, number one. Number two, there should be a mandatory insurance for everybody in this country. When I say mandatory insurance, that means it should be by law. You should not be allowed to walk on the road if you don't have a health insurance. Like, for example, we can't drive a car without insurance. Similarly, you have to have a certificate that you have insurance by law. People who can afford, they should pay their own premium. People who are employed, it should be 50-50. Employer 50%, employee should pay 50%. For example, if I am my driver or a cook in my home, it should be my responsibility that to make their health insurance. Some money I should pay, some money they should pay. Why they should pay? Because otherwise they will not understand the value of this thing. But there are people who don't have money at all. Then the government should pay. They take taxes from us. They should spend on those poor people. So if the government goes in the direction of mandatory insurance, I think we can treat everybody. Then finally, but not the, perhaps the most important thing is that in this country, we have a lot of cardiovascular disease. Cardiovascular disease is number one killer in the world and in India also. But it is sad story that there is no structured health education program in the country. For example, we had a national tuberculosis prevention program, and recently our Prime Minister has vowed that we want to finish it. That's few years time. We want to end this tuberculosis rahat Bharat. Similarly, government has to take a pledge, heart disease rahat Bharat. You can say 10 years or 15 years, but it is possible to decrease the burden of cardiovascular disease. Now I'll share with you 2020-21 data, WHO data. 18 million people died because of cardiovascular disease. 18 million. If those people, they had adopted a good lifestyle, no smoking, exercise, LDL reduction, blood pressure reduction, stress management, that means primary prevention of heart disease, 70% of those premature deaths are preventable, 70%. So that is the impact of prevention. So that's what the government should do.
Nice to know. Hope they do that. How heart attacks in women differ from men, and how women are as vulnerable to heart attacks as their male counterparts. Like, whenever we talk about heart attacks, it goes only to the male part. We don't talk about the women.
Very good question.
So how do we do it?
Excellent question. First of all, 20 years back, we believed, quote unquote, believed everybody that any female who is premenopausal, that means her menses are still going on, she will not have heart disease, practically speaking. So we used to think only 50 plus that she may have, but not anymore. Now we are seeing heart disease in young females, even menstruating ladies, even in 30s and in 40s. Now, why that has happened, I don't have complete answers to that. Again, I would say that the socio-economic structure in the country has changed in the last 20-25 years. Females are competing in everything in life. Diabetes is getting more and more in India, and females are not spared. So I think it is a multiplicity of factors that females are getting heart disease. So I would recommend that we used to say men more than 35 and females more than 50 should have a regular cardiac checkup. But now I will revise my criteria that men or women, doesn't matter any. I think we should start cardiac checkup at the age of 30 years in this country.
So, and smoking and drinking in women would it is more, it affects the heart more than male, is it so?
Yes, you are right. The same amount of liquor or same amount of smoke is more dangerous for a female than a man, because in men arteries are bigger size, in female they are smaller. And there's another issue in female, that in females the symptoms of heart disease are little atypical. They are not classical book pattern. So it is much more likely to be missed. They may say pain here and there, which is not classical description of a heart attack. So in female, symptoms are more atypical. Then there are TMTs. If you do TMT, false positive are more in female. So in female, even if you have if you do angioplasty, the outcomes are less favorable as compared to men. Even bypass surgery, for example, their longevity of bypass grafts is lesser as compared to a man. So there are many disadvantages they have. But still, I would say that as long as they are menstruating, they are partly protected from coronary artery disease.
What advice can you provide to young doctors who are wishing to pursue a career in interventional cardiology?
Rephrase this question, that who should become a good doctor? Who should become a doctor? Okay. I think anybody who has a passion and interest to become a doctor should become a doctor. And they should understand, the younger generation in colleges, for example 9th, 10th class, I want to tell every student of this country that don't select medicine because it will bring more money to you. No, this is wrong. Medicine doesn't bring too much of it, brings good money, but there are many other professions where you can earn much more money. But if you like interaction with the human beings, if you like treat the suffering people, and if you have empathy in you, if you are empathetic, sympathetic if somebody is suffering, then you should become doctor. In my opinion, there is no better profession in the whole world than medicine, because I think myself to be blessed that God has selected me to become a doctor. I can treat my own fellow beings. What else? I could have earned money anywhere else. So I think it's a great profession. And today's age belongs to interventional cardiologists. So when we talk about the interventional cardiologist, it's the best time in the era of medicine, that you can have so many technologies, you can treat so many patients. So it's fantastic.
Thanks a lot, doctor. Thanks for giving us time once again. It was great to know a lot of things.
My pleasure. It's a great pleasure to talk to your team. Thank you very much.
Thank you.